Thank you very much for inviting me to Asian Pacific Leadership Series webinar organized jointly by Asian Pacific Society of Cardiology and Japan Circulation Society. I welcome you all to my presentation on scenario of cardiovascular disease in Bangladesh. I am Professor Mohibullah, President, Bangladesh Cardiac Society. First of all, I shall talk on the present situation of cardiovascular disease in Bangladesh, and then on facilities available in the country, and lastly on limitations they are facing. These data are compiled by Bangladesh Cardiac Society from different hospitals of the country having cardiovascular care facilities. Here is global scenario of non-communicable disease and cardiovascular deaths. In the USA, it is 31%, and it has been published in 2014 and 2018. In Bangladesh, 17% of the total death is due to cardiovascular diseases in 2014, and 2018, it was 30%. Here is a country picture. We have 170 million people having per capita income of around USD 2,500 US dollar. We are gradually going to low middle income countries, and we have the areas of more than 57,000 square miles. Here is national health indicators. In recent years, there are much improvement in national health indicators, particularly in infant and maternal mortality, but health budgets per capita, health expenditure, and population physician-nurse ratio are yet not satisfactory. Health budget is less than 1%. For 170 million people, we have about only 150,000 hospital beds. Doctor-people ratio is 1 doctor for 1,600 people. And if we consider the rural population, then the situation is more grave. Dear participant, in last 3 decades, Bangladesh is facing epidemiological transition of the disease. Communicable diseases are decreasing and non-communicable diseases are increasing. This has happened due to socio-economic development and lifestyle changes of the people. There are improvement in national health status, safe drinking water, and sanitation. On the other hand, there is increase in tobacco consumption, saturated fat intake, and decrease in physical activities. These all together contribute to the epidemiological transition of the diseases. The major cause of death in Bangladesh gradually shifted from infectious and parasitic diseases to the non-communicable diseases, and cardiovascular diseases are responsible for more than 30% of the total deaths. Here is the slide showing the different non-communicable diseases prevalence in the country. NCDs are estimated to account for 67% of all deaths. In Bangladesh, we have all sorts of cardiac diseases, coronary artery diseases and hypertension, rheumatic heart diseases, congenital heart diseases, arrhythmias, heart failure, cardiomyopathy, and strokes. The burden of rheumatic fever and rheumatic heart disease has declined due to awareness of the people and effective preventive programs. On the other hand, the coronary artery disease and hypertension are increasing. Here are several studies on prevalence of hypertension in the country involving urban and rural population of different age groups. First of this kind was conducted in 1976 on 7,000 population, and the prevalence of hypertension was found as 1.21%. Over the years, it has now raised to 15 to 24%. Of all these studies, hypertension, NCD risk factor survey and Bangladesh Demographic Health Survey 2011 is very much notable. And both the studies show that the prevalence of hypertension was found as 24%. This is published in 2015 in journal by analyzing 7,800 cases over the age of 35 years. They found the prevalence of hypertension as 24.4%. They have shown that only 50% case of hypertension cases are diagnosed. Out of this, 41% are taking treatment, of which 32% are controlled. A large number of hypertensive patients are yet undetected and out of the care. Out of care. Here is a slide showing hypertension. This is a systematic review and meta-analysis of different slides showing the prevalence of hypertension and it's the trend of Bangladesh. And overall weighted pool prevalence was found as 20%. Coronary artery diseases are increasing in the country. Epidemiological studies in this field are few. The prevalence of the disease was reported as 0.33% in 1976, whereas in 2011 it has increased to 5.1%. So socioeconomic improvement of the people over the years, as well as changes in lifestyle, increase in tobacco consumption and structure and saturated fat intake, and decrease in physical activity may be the factors for this increase. Moreover, young onset and aggressive presentation of the disease is seen in our country, but why this is so, we cannot say as yet. This is 10 years cardiovascular risk among Bangladeshi population have shown that 1 in every 4 Bangladeshi adults had elevated cardiovascular risk, and males are higher in risk. Over the last several years, rheumatic fever and rheumatic heart disease has declined from 7.3 per thousand to less than 1%, even less than that. It has become possible because of the increased awareness of the people and socio-economic improvement and environmental improvement and effective prevention program. Here I have to mention that the preventing the rheumatic fever and heart diseases in Bangladesh, Japan government through JICA helped us a lot. We are very much grateful to them. We do not have enough data on congenital heart disease from hospital data. It was revealed that the incidence of congenital heart disease are 25 to 30 per thousand life. But here is 2 hospital statistics are shown. One is in combined military hospital and one is medical college hospital. We do. We have very few studies in the incidence of heart failure. It is varying from 14 to 29% into hospital admitted in this hospital. Overall prevalence of stroke was 0.3% in patient above the age of 40 years. In another study, it was found as 0.9% in rural population only over the age of 30 years. At present, we do not have any preventable data regarding arrhythmias, cardiomyopathies, and peripheral arterial diseases. We have already taken this step in this regard to find out this data. In summarizing the data so far presented, we can assume the prevalence of hypertension as 15 to 24%, coronary disease 4 to 6%, and rheumatic fever is less than 1%, congenital heart disease is 25 to 30%. And we do not have any community data on heart failure, arrhythmia, cardiomyopathies, and peripheral arterial diseases. Here is the prevalence of risk factors of cardiovascular diseases in Bangladesh as shown, and diabetes mellitus is responsible for 5.9%, and smoking has been found in 40%, and dyslipidemia is 34%, hypertension is 52%. And prevalence of metabolic syndrome in Bangladesh, a systematic review and meta-analysis of the studies published in 2018 shown that the metabolic syndrome was found as 30% in our country. So long I have presented the scenario of cardiovascular disease in Bangladesh. Now I shall give some highlights. on cardiovascular care facilities in the country and our achievement in this field. Cardiovascular care facilities have started taking off in the country in the late 70s of the last century with the establishment of the National Cardiovascular Diseases and Cardiology units in 8 medical college hospitals in 1978 with the help of JICA and Japan government. Besides rendering cardiac care services, the institute has taken the program of developing cardiologists, cardiac surgeons, and technical manpower. In last 2 years, we cannot take any data due to corona pandemic. We are presenting the data of 2017. Number of cardiologists in the country is around 1,000 and number of cardiac surgeons is around 200. We have 65 hospitals with cardiovascular care facilities and 26 hospitals with cardiac surgery care facilities. So we have 5.8 cardiologists for 1 million population, 1.2 cardiac surgeons for 1 million population. Our cardiac care facilities is very poor. Total number of cardiac beds in the country is around 4,000 and CCU bed is around 1,300. And 2.6 bed per 100,000 population and CCU bed is less than 0.83%, and international recommended bed number of beds is 4 to 5 CCU beds per 100,000 population. We have 70 cath labs in 44 centers and 52 cardiac operation theaters in 25 centers. Here is the procedures performed in the last 6 years have shown that in 2011 it was done as about 22,000, and in 2018 it has raised to 48,000, almost double. And PCI as well as primary PCIs have also increased last 6 years in 3 folds. Here is the procedure performed from 2006 and 2008. It's gradually increasing. Interventional procedures has been shown in this slides, and it has been 2018. It has almost 76,000 interventions. 76,000 interventional procedures have been done in 2018. Here is cardiovascular surgeries have been done in 2014, 2018. It is gradually increasing. In 2018, total cardiovascular surgeries have been done more than 10,000. Here is cardiovascular surgeries done in last 5 years. We do not have enough data on cardiovascular mortality. Here is the data on mortality in our National Cardiovascular Hospital as shown. In 2007, it was 7.9%, and in 2017, it was 6.6%. There was not much improvement in this sector, in this mortality of the diseases. This is a different sort of slide showing the number of manpower in cardiology in different countries. In Germany, it is shown that 44 cardiologists have cardiologists for every million of population, but in Bangladesh it is 7.1 for 1 million population. American College of Cardiology and EU recommendation is 40 to 50 cardiac specialists per million population. And dear participant, I am towards the end of the lecture. I shall now present the limitations and problems we are facing presently and how we can overcome it. We have inadequate manpower, in particular cardiologists, cardiac surgeons, specialized nurses and technicians, as well as insufficient logistics, number of hospital beds, number of cath labs, and number of surgical facilities. And cardiac specialists and cardiac centers are unevenly distributed in the country, mostly Dhaka centered. Technical training program are not adequate and well planned and adequate. Cardiologists, cardiac surgeons, and technicians and cardiac surgeons this training. Problem in maintenance of specialized equipment, supply of power in respect of position and manpower, and cost of investigations, medicine, cardiac devices and procedures are not within the reach of common people. Government sector is not optimally designed in respect of manpower, cardiac beds and facilities. Private sector is not keen to manpower for manpower development. We are lacking of national guidelines. We do not have any basic research. Epidemiological and clinical data are very poor. We do not have yet national registries. Emergency care are not well organized and easily available. Preventive services are largely overlooked. Here is a slide for secondary preventive care for cardiovascular disease in Bangladesh. A national survey done and published in 2021 shows that grossly insufficient acute and chronic cardiovascular care capacity in Bangladesh. More than 50% of all centers are located in Greater Dhaka. 70% of the district have no specialized cardiovascular care. So what we have to do now? Government has to take more initiative to extend and improve cardiac care facilities in the country, particularly in government hospital, and to bring down the cost of the treatment to the reach of our common people. Private sector in this field should adopt policies of developing manpower and reducing cost. Societies and foundations should take lead in developing guidelines, registries, and resources. We have to overcome this problem and shortcomings to achieve the adequacy in this field. To keep pace with modern cardiology, it is essential to improve the present situation, to introduce the newer procedures and facilities. And it requires coordinated action of all stakeholders, including government, cardiac healthcare professionals, policymakers, individuals, and societies and foundations at all levels. Thank you very much. Thank you once again.